So I am a diagnostic radiologist and a nuclear medicine physician. So I have expertise in both anatomic as well as functional imaging for malignancy. While I was at Memorial Sloan Kettering, I was the molecular imaging representative to the breast cancer disease management team at Memorial Sloan Kettering. So I had the privilege of working with some of the best surgical oncologists, radiation oncologists, medical oncologists for the treatment of breast cancer, and developed an interest of my own in the imaging of breast cancer. In particular for lobular breast cancer, because as many people don't realize, lobular breast cancer is a very different malignancy than the more common ductal breast malignancy. It has a different genetic basis, it has a different pathologic basis, and this leads to different imaging of the tumor as compared to the more typical invasive ductal malignancy. Lobular breast cancer is more difficult to detect on all currently known imaging modalities, such as mammography, ultrasound, MR, and FDG PET scanning. So I developed an interest in using newer targeted methods of imaging to help visualize lobular breast cancer in hopes that that would translate into better staging, better treatment choices, and better outcomes for patients with lobular breast cancer. I was invited to become part of the Lobular Breast Cancer Alliance by its initial founders and by Dr. Steffi Oesterich. As I had been performing research on lobular breast cancer, and at that time there were very few people that were specifically interested in lobular breast cancer and its imaging and therapy. Lobular breast cancers are almost always estrogen receptor positive, which gives us an opportunity to take advantage of that estrogen receptor for imaging and therapy of lobular breast cancer patients. There is a novel positron emission tomography, or PET radiotracer, known as 18F fluorestradiol, or FES. So FES is a radio-labeled estrogen. The estrogen allows us to target the estrogen receptor, and the radio label allows us to visualize where the estrogen goes by using sensitive radiation cameras called positron emission tomography, or PET cameras. And we have some initial data demonstrating that the FES agent for estrogen receptor targeted imaging is valuable for imaging lobular breast cancer where other imaging modalities have failed. So this is an example of FES, or fluorestradiol, or radio-labeled estrogen imaging, compared with the typical fluorodeoxyglucose, or FDG imaging. Fluorodeoxyglucose, which has been around for quite some time, uses a radio-labeled sugar molecule. And as most malignancies like to eat sugar for their energy source, you're able to visualize metastatic disease using FDG PET scans. However, here's an example of 5 different patients, as you can go from the head down to the lower thigh. There's very little malignancy visualized on the FDG scan. There is normal brain, heart, liver, kidney, and bladder uptake, which is not malignancy. And there is on these patients, unfortunately, areas pointed to by some of the red arrows demonstrating that there is a metastatic disease in these patients. But compare that to the radio-labeled estrogen, the FES, where the physiologic activity is here in the liver and the bowel, we can see much more extensive here, unfortunately, osseous malignancy in the patient when the patients are imaged with our radiolabeled estrogen than when they're imaged by the typical FDG. To the extent that in some patients there is disease picked up on the FES scan, which is no disease is detected by FDG. So these are just a few examples of how this novel radiolabeled estrogen PET tracer can help us detect disease and determine the extent of disease that is overlooked by more conventional standard of care imaging methods. Well, I like to say it's hard to treat something that you don't know exists. And also you can better treat something when you know where it's located. So two particular questions when regarding selection of treatments for the disease is where is it and how much is there? So very small volume disease that's localized to one or two sites could be treated by local therapies such as radiation, external beam radiation. Whereas more extensive disease or more widely spaced disease typically requires systemic therapies, things that are administered into your vein and then circulate throughout the entire body. So if you were incorrect about how extensive your disease was or where it is located, you can end up getting suboptimal therapy for your disease. So with this imaging, if we can more precisely quantitate how much disease is present and more specifically localize where the disease is located, then a medical oncologist, radiation oncologist will be able to better determine which methods of therapy will be best in individual patients. Another really promising application will be in patients who are newly diagnosed with breast cancer. Where there, if you have disease localized to the breast and the local lymph nodes, the appropriate treatment would be neoadjuvant systemic therapy followed by surgery, which is the goal there is to remove all disease and effect a cure. However, we know that for some patients, this therapy choice is very successful, and in other patients, recur with disease, and that's elsewhere in the body, and that's probably because there was disease already that which had already spread, but was unknown about at the time of the surgery. These new sensitive methods of imaging will allow a better selection of patients that are truly only local disease versus patients who are truly metastatic at presentation, and thus you can better select patients for that initial treatment by neoadjuvant therapy and surgery for local disease versus more systemic therapy approaches for patients that unfortunately have metastatic disease at presentation. You work with a phenomenal team of physicians that are interested in optimal care of patients. At both Memorial Sloan Kettering as well as here at the Hoag Family Cancer Institute, there are just wonderful people to work with that are interested both in optimal care of patients as well as development of the next level of imaging and therapy for patients. So in order to find patients, I rely upon the surgical oncologists and the medical oncologists that I work with, who refer appropriate patients to me for imaging trials. A smaller subset is patient-initiated contacts where I received phone calls from people around the country saying, I have lobular breast cancer. Am I appropriate for your clinical trials? And sometimes they are, and sometimes they are not. But this is one way that patients are knowledgeable patients are really looking out for the latest and most valuable ways of imaging and treating their tumors, and are reaching out to us even before we reach out to them. Well, trials have their benefits and their drawbacks, just like all things. Many of these benefits, I think, are apparent. If we better detect and localize disease, then people can benefit from better therapies for their malignancy. But these trials are research, and they require more visits to the hospital. They sometimes require more imaging tests. They may require more biopsies that are than otherwise would be performed. So there are some perceived drawbacks to participating in clinical trials. So we lay out all the potential benefits and potential risks in what's called an informed consent. And these informed consent forms need to be discussed with potential subjects, and we sign a written informed consent before proceeding. And to some people, the risks may not be worth it to them, but the vast majority of people see the benefits as far outweighing the risks, and we have not had difficulty when we explain the benefits and risks. We tend to have a problem of abundance. Sometimes there are more people interested in a trial than we have the capacity to accommodate. Even now, I think most, and I'll speak first for radiologists, radiologists often receive a referral for an evaluation of images for breast cancer. And most radiologists still treat breast cancer as all being the same. At certain academic medical centers, there are specialists that really appreciate the differences between the different histologies of breast cancer. And to me, lobular breast cancer is something that needs to be recognized as being more difficult to detect on certain imaging modalities. So educating the physicians that are interpreting these studies to be cognizant of the differences of lobular breast cancer is really important. Now, sometimes that can have impact and sometimes it can't. So for example, on a mammogram, if we say it's more difficult to see lobular breast cancer on a mammogram, well, sometimes you just can't see anything on the mammogram. So being cognizant that it's lobular breast cancer may not improve your reading, that probably won't improve your reading of the mammogram. You just unfortunately sometimes can't see the disease no matter how good you are. On an FDG PET CT, I think that's a little different, because being cognizant that lobular breast cancer may not be FDG avid makes you look a little harder at the CT scan to see subtle clues of malignancy that could be missed if you weren't looking for non-FDG avid malignancy. I think that there are going to be more and more both imaging and clinical trials that specifically evaluate the lobular breast cancer as a separate subpopulation of breast cancer in their trials. Many trials of agents, they report their their efficacy in breast cancer. And I think it's going to be exciting to see more and more trials demonstrating that perhaps there is a greater or lesser advantage of their novel agents in lobular breast cancer as compared to breast cancer as a whole. And people are recognizing that this is really important because of how common lobular breast cancer truly is. I think there's a misconception that lobular breast cancer is rare. We say that lobular breast cancer only represents maybe 15% of all breast cancers. But when you consider just how common breast cancer is, 15% of something that's really common is still really common. So if lobular breast cancer was considered its own malignancy, it would be the 6th most common cancer in women. And I think people are really coming around now to appreciate that lobular breast cancer is not a rare disease. It's actually a very common disease that needs a greater focus for education and research. The first is on research trials. I've actually found it very helpful to have advocates who participate in the research trial design. Sometimes the advocates have a perspective that the physicians do not have, and that leads to improvements in the trial designs. And one of my trials that was of a amino acid tracer for evaluation of lobular breast cancer was substantially impacted by the participation of advocates right up front in the trial design. A second area which I originally thought might be very impactful, but I've found over time hasn't necessarily been needed so much, was to have advocates willing to speak to patients who are potential accrual onto research trials. I thought maybe it would be valuable for people to have other lobular breast cancer patients available to speak to when they were considering being accrued onto trials. That might help them maybe relax a little about being part of a trial if they could speak to someone who had previously been on a trial. But actually, at this point in time, I haven't had that many people say that they were worried about being accrued onto a research trial and therefore needed to speak with an advocate. And then a final area where advocates can be valuable then is, of course, in patient support. I think people get frustrated when they have lobular breast cancer because sometimes reports will say no evidence of disease, and then the advocates are reading, or patients are reading that, well, sometimes the disease is there and we just can't see it. And it's very helpful to have people who have been through it before to speak to people who are now going through it for the first time to help them cope with these difficulties and realize that medicine is good but not perfect, and we do the very best that we can for the patients that we encounter. Knowledgeable lobular breast cancer patients will recognize that imaging may be less effective for finding lobular breast cancer than the more common ductal breast malignancy. So it could be valuable for patients to inform their referring clinician to note that they have lobular breast cancer on requisition for imaging tests, so that physicians that are aware of these differences then are aware to look for these differences. I say that when I read an FDG PET CT scan on a patient that comes with breast cancer, I always go to the histology, go to the pathology and look up what histology of the breast cancer is, to be aware of any differences between ductal and lobular malignancies. But if it was reported to me that it was a lobular breast cancer patient, that would draw my attention to it without me having to look for details within the medical record.